conclusion of this presentation, participants should be able to discuss methods of oocyte insemination, including conventional and intracytoplasmic sperm injection, or ICSI, and explain the difference between the methods. Describe oocyte handling, including cumulus removal, maturation assessment, and injection methods for ICSI. Identify sperm preparation methods for standard insemination and ICSI cases, and sperm handling for ICSI. And describe the timing of insemination for conventional and ICSI cases. The world of assisted reproductive technology, or ART, began when the first successful fertilization of a human oocyte was achieved in 1968 in Cambridge, England, by Sir Robert Edwards. It started in a single laboratory in England, but has since grown to be a worldwide technique used with in vitro fertilization. With such an integral and powerful tool, proper procedure is crucial. IVF insemination is composed of sperm selection via washing with media or density gradient separation to select motile sperm to add to the eggs in culture. ICSI is an all-encompassing procedure that utilizes many different tools to manipulate both sperm and eggs with a number of different outcomes. A variety of steps comprising the procedure will be discussed in this module: semen processing, oocyte preparation, microinjection setting, sperm selection, assessment of oocyte maturity and penetration, and evaluation of fertilization. Some overall concerns related to the procedure will also be covered. Sperm can be obtained by ejaculation or surgical retrieval from many different sources. Ejaculated origins include fresh semen, frozen, electroejaculate, vibration-induced, and retrograde. Surgically retrieved sperm are either epididymal or of testicular origin. Many factors impact insemination in vitro. One of the most important is the original semen analysis on the ejaculate. An accurate sperm count and motility are essential to the following steps involving insemination, as the initial count and motility will determine the type of insemination that is done in vitro. These steps are determined by an analysis which uses a counting chamber to evaluate concentration and motility, as well as morphology slides to determine the amount of normal forms. The lower reference values according to the World Health Organization are shown here. Raw semen must undergo processing in order to best prepare the sperm for fertilization. This process rids the sample of unwanted debris, seminal plasma, and dead sperm, while selecting the sperm most likely to fertilize. Spermatozoa selection involves removal of the seminal fluid by centrifugation. Either a swim-up method or density gradient method can be used. With swim-up, the semen is allowed to liquefy for 30 to 60 minutes. After count and motility, it is diluted with 3 volumes of sperm wash media and mixed. The tubes are then centrifuged for 10 minutes at 250 Gs. The supernatant is removed with a sterile pipette, and the pellet is suspended in 1 milliliter of media. The count and motility are repeated, and the tube placed at 37 degrees Celsius for 60 minutes. Motile sperm are collected from the top of the media, the count and motility are calculated, and the sperm are ready for insemination. Note that many labs suspend the sperm pellet in the same culture media as that used for the eggs. If this is done, sperm swim-up must be done in a 37 degrees Celsius CO2 incubator. Density gradient separation allows for motile sperm to be concentrated in the bottom of the tube, whereas non-motile sperm, other cellular debris, and the seminal plasma stay on top of the gradient. After centrifugation, the seminal plasma and non-motile fraction of sperm are removed from the tube. The motile sperm are transferred to a second, clean tube and centrifuged with culture media for a final wash. That supernatant is removed and the sperm suspended in up to 1 milliliter of culture media for count and motility determination prior to insemination concentration determination. Once the motile sperm have been separated from the ejaculate and washed in culture media, the final concentration and motility are determined. Motile sperm are suspended in an amount of media that allows for insemination of 2.5 to 5 times 10 to the fourth motile sperm per milliliter. This range is the optimum concentration for normal fertilization in vitro. Timing of insemination is carefully calculated within parameters of retrieval time, egg maturity, and fertilization check. Egg maturity should be assessed prior to insemination by the appearance of their cumulus complexes. Conventional insemination is typically done a minimum of 2 hours after egg retrieval and culture. However, the timing can be altered based upon oocyte maturity and egg retrieval time. Insemination of the oocytes after maturity assessment must occur such that the timing of fertilization check is 16 to 20 hours post-insemination. Ideally, a fertilization check is done first thing in the morning, the day after insemination. Eggs are removed from insemination media, cumulus cells removed mechanically, and fertilization assessed. Oocyte identification at egg retrieval. This video shows eggs in culture after egg retrieval. Note the polar body and the cumulus complex. This is a metaphase 2 or mature oocyte. Sperm after being processed through a density gradient are shown here. These sperm are in culture media prior to addition to oocytes. All human eggs upon receipt in the lab must be graded as to their maturity. It is generally assumed that due to stimulation of several follicles during follicular stimulation protocols, that not all eggs will be mature at the time of aspiration. Upon location of the egg in the follicular aspirate, maturity can be judged by the morphology of the surrounding cumulus and corona cells. This system is used mainly because visualization of the cytoplasm of the egg itself is rarely possible due to the surrounding cells. Based on the maturity of the egg, insemination time can be judged, that is, a mature egg can be inseminated in 2 to 4 hours, whereas an immature egg may need as much as 24 hours of incubation prior to insemination. The grading system employed here is based upon the Veek system in 1986. This video shows sperm and oocyte after sperm addition to oocyte culture. Oocytes are prepared for ICSI by removing the surrounding cells, the cumulus and corona. This is accomplished by placing the oocyte complex into HTF HEAPS buffered media containing hyaluronidase. HEAPS buffer is better at maintaining physiologic pH in room air than bicarbonate buffer used in oocyte and embryo culture media in a CO2 incubator used to maintain media pH. Hyaluronidase is an enzyme that breaks down the bonds between cumulus and corona cells, making them easier to remove mechanically from the oocyte. Hyaluronidase is also found in the acrosome of sperm. Once the surrounding cells are removed, the oocytes are examined for maturity. Oocytes are graded as mature, M2, or immature, which includes metaphase 1, M1, germinal vesicle stage, degenerated and abnormal oocytes. Only M2 oocytes are injected with sperm because those are mature. M1 oocytes may be cultured for several hours and become M2 and then be injected. ICSI tools are very important. ICSI pipettes are made from borosilicate glass capillary tubes and are available from several companies. The holding pipette has a 60 to 180 micrometer outer diameter and a 15 to 20 micrometer inner diameter. The injection pipette has an 8 to 10 micrometer outer diameter and a 4.3 to 7 micrometer inner diameter. A 30-degree bevel angle is made at its end, forming a sharp spike that allows the piercing of the zona pellucida and the oocyte. Since the pipettes are actually fixed at an angle to the dish, both pipettes must be bent to be able to perform the procedure with the tool tips horizontal on the dish. The micro tool holders allow for adjustment of the angle of the pipettes. The microinjection setup allows the embryologist extremely finite control during the procedure. The setting includes an inverted microscope capable of 400 to 600x magnification connected to a video system. The microscope has a heated stage, 2 electric motor-driven coarse and fine control manipulators, and 2 microinjectors. The microscope must be equipped with Nomarski or other phase interference optics. ICSI takes place in a prepared, shallow, 50 by 9 millimeter microinjection dish. This dish is set up to allow the operator to move between a central drop of sperm and droplets of oocytes. The microinjection dish, or ICSI dish, contains 9 total drops. The central drop contains polyvinyl pyrrolidine, or PVP, and is where spermatozoa are added. The surrounding drops contain heaps buffered media and the oocytes. All droplets are covered with lightweight paraffin oil. The number of drops or oocytes added to the dish may be different and configuration of drops may vary. One variation is an elongated PVP drop below several 30 microliter drops of heaps buffered media for oocytes. ICSI must be completed quickly to minimize oocyte exposure time out of the incubator. In standard media, individual spermatozoa can be difficult to inspect, immobilize, and aspirate due to their motility and speed. The most common method of neutralizing these issues is the use of 7 to 10% PVP solution as a sperm capture medium. PVP has a number of functions. It allows for sperm morphology and 3-dimensional motility pattern and evaluation, which helps related procedures like intracytoplasmic morphologically selected sperm injection, or IMSI. It also facilitates aspiration and facilitates sperm immobilization by minimizing the likelihood of sperm sticking to the dish and the injection pipette. PVP is not essential to injection, but most centers do continue to use it. Immobilization is a technique in which the embryologist rubs the tail of the sperm against the dish with the ICSI pipette, causing damage to the sperm plasma membrane. This releases sperm cytosolic components involved in oocyte activation. Damage inflicted to the sperm flagellum results in membrane destabilization and consequential acrosome reaction. Combination of these parameters is a prerequisite for fertilization. To prepare for injection, the embryologist must adjust the oocyte position. The embryologist should focus in on the oocyte, lowering the holding pipette and ICSI pipette, and rotate the oocyte using both the holding and the injection pipettes. Rotating the oocyte helps find the polar body. The polar body should be placed at either 6 or 12 o'clock. Note that it is helpful to focus on the oocyte first, then gradually move the ICSI tool into focus. Preceding zona pellucida piercing, the holding pipette is used to hold the oocyte in place by suction. The oocyte should be touching the bottom of the dish. After the injection pipette is lowered so it is focused on the oolemma at 3 o'clock, a level plane is created through the holding pipette, the oocyte, and the injection pipette to allow the injection to pierce the oocyte correctly. Advance the sperm to the tip of the ICSI pipette. With consistent thrust, the membrane break will happen around the center of the egg. Slight positive pressure from contents of the ICSI pipette and sperm are beneficial. Once the pipette is 3/4 of the way into the oocyte cytoplasm, stop advancing the pipette. Aspirate cytoplasm into the ICSI pipette with negative pressure until the sperm, previously at the tip of the pipette is at the outside of the zona pellucida and the plasma membrane pops or gives way as evidenced by less resistance on the negative pressure in the ICSI pipette. This demonstrates the breach of the plasma membrane and is essential for fertilization and oocyte activation. After membrane break and cytoplasm aspiration, the injection pipette is located inside the oocyte. Eject the sperm slowly, avoiding the injection of unnecessary medium. The sperm should not stick to the tip of the pipette. This can be avoided by slightly withdrawing the pipette as the sperm and cytoplasm are being deposited back into the oocyte. Completely withdraw the ICSI pipette in a straight line. Do not move the pipette inside the oocyte in any plane and withdraw the pipette straight out of the oocyte. Remove the injection pipette slowly. The breech area should maintain the slight funnel shape or return to pre-injection status. Observe the injection site for any cytoplasm leakage into the perivitelline space or other oocyte damage. Average injection time should be less than 30 seconds per oocyte. IMSI, or intracytoplasmic morphologically selected sperm injection, is another method popularized in recent years. The process involves very high magnification of motile spermatozoa in PVP. The sperm are selected based upon specific criteria, including normally shaped nuclei, no more than one nuclear vacuole, and specific length and width parameters. These sperm are separated into a second PVP drop and used for injection. Receiver operating curve analysis demonstrated that normalcy of the sperm nucleus had predictive value for pregnancy occurrence. This finding suggests that ICSI outcome may be improved by the exclusive microinjection into the oocyte of a spermatozoon with a normal nucleus. For semen samples with 20% or less motility, a density gradient separation is not advisable. Using a gradient may reduce the number of motile sperm too much. The simplest and most effective method is a swim-up. Complete the initial motility and count and add 3 volumes of sperm wash media to one of the semen. Mix the sample well and place into 15 milliliter conical tubes. Centrifuge at 340 Gs for 10 minutes. Remove the supernatant carefully so as not to disturb the pellet. Gently resuspend the pellet and overlay it with 0.3 milliliters of sperm wash media. Allow motile sperm to swim into the upper media for 60 to 120 minutes and collect sperm from the motile fraction for ICSI. Sperm for ICSI from testicular sperm extraction, or TESE, samples is complex. The sperm must be extracted from the seminiferous tubules and/or testicular tissue prior to use for ICSI and/or freezing. The samples usually contain blood, so initial washing with sperm wash media containing heaps is needed. After washing, the tubules can be individually dissected using a fine gauge needle under the dissecting microscope. Tubules with active sperm production will have a plump appearance and be opaque, and when dissected, fluid and sperm will emerge from tubules. Collect the fluid, centrifuge, and look for sperm. Use of a tissue grinder is a good way to achieve uniform tissue homogenization. The tissue grinder is a manual device that is individually packaged and sterile. The homogenized tissue solution is placed into microdrops of culture media under oil. Any motile sperm will migrate to the edges of the drop, and the drop can be searched under the inverted microscope for any non-motile sperm. Motile and non-motile sperm are collected and used for ICSI. Sperm are collected from the outer drops after a portion of the minced tissue is placed in each drop, allowing for sperm to acquire motility and migrate to the outer edges of the drops. The sperm are aspirated with an ICSI pipette, placed in the central PVP drop, and the membrane disrupted. Individual sperm may take several hours to overnight to migrate from tissue to be collected. Covered dishes are kept in a laminar flow hood for incubation. Plates are not heated, but are at room temperature until search and observation of sperm. The central drop for oocytes is replaced with fresh, warmed media prior to oocyte deposition for ICSI. Cryopreserve any ground tissue or sperm not used for ICSI. Percutaneous epididymal aspiration, or PESA, generally is used in men with obstructive azoospermia and involves surgical aspiration of the epididymis by a urologist. Sperm from PESA is easier to locate than sperm from testicular tissue, but less abundant in most cases than poor ejaculated samples. The sperm are generally not motile initially and may acquire motility after culture in sperm wash media. These samples require concentrating by centrifugation and resuspension in fresh sperm wash media in a small volume. If sufficient numbers are present, sperm can be added to PVP for ICSI. If numbers and/or motility are low, then the concentrated sperm must be added to microdrops of media and allowed to migrate to the drop edge for pickup for ICSI. Sperm are collected from the outer drops after a portion of the PESA is placed in each drop, allowing for sperm to acquire motility and migrate to the outer edges of the drops. The sperm are aspirated with an ICSI pipette, placed in the central PVP drop, and the membrane disrupted. Individual sperm from PESA may take several hours to migrate to be collected. Covered dishes are kept in a laminar flow hood for incubation. Plates are not heated but are at room temperature until search and observation of sperm. The central drop for oocytes is replaced with fresh warmed media prior to oocyte deposition for ICSI. Thank you for participating in this educational activity.